Welcome everybody to the May edition of the Sustainable Kidney Care Network webinar series hosted by the Centre for Sustainable Healthcare. The webinars take place on the fourth Thursday of every month from 2 to 2:50 UK time. Last month we had Jan Sai present on reducing energy and consumable use in dialysate production, as well as lots of other, well, 3 fantastic research projects coming out of UMC Utrecht. So for those who missed it, there is a link that will be posted in the chat. So definitely recommend catching up on that to see really what's happening at the cutting edge of sustainable kidney care research. Likewise, if you've missed any of our webinars, or if the time falls when you can't join live, then you can catch up with all of them, as well as the case library, resources, and engage with peers all around the world on our networks page, which I really recommend people join and keep up to date with. So a couple of announcements just at the top of the webinar. First of all, a reminder that our Sustainable Kidney Care online learning module is live. This is part of KitNew Care, and it focuses on the bidirectional relationship between kidney care and climate change and the practical changes that you can make. And it's aimed at everybody with an interest in kidney care. So regardless of if you're a renal technician, a dialysis nurse, a nephrologist, a student, a researcher, there's something in there for everyone. So definitely check that out. Secondly, for those who use our networks, and if you don't, you should, but please fill out this form to help us improve it. Little bit of housekeeping. So a reminder for people to mute their mics. There's no need for AI note taker. We'll record this and we'll post it afterwards. Please try and save questions until the end, and we can have a discussion at the end of the webinar. And for that period, if you're comfortable to turn your cameras back on, it really helps facilitate a better discussion. And lastly, if people do want to present, then reach out to me and we can organize. So that is all the housekeeping, which brings me to introduce our speaker for today, Professor Raymond Vanholder, who wanted to just be called Ray, but I'm going to address him by his title because it's deserved. If anybody wants to feel like their academic achievements don't measure up, then go and have a read of Ray's bio. Is the quickest way to do that, because it's phenomenal. He's been published more than 900 times, including reviews and book chapters on adequacy of dialysis, uremic toxicity, and various topics related to clinical nephrology, especially cardiovascular and infectious complications, green nephrology, and socio-economic aspects of kidney care. He serves as a member of the editorial review board of several journals and is subject editor of Nephrology, Dialysis and Transplantations, and Toxins. Up until autumn 2010, he has been chairman of the European Uremic Toxin Work Group, EUTox, and a member of the executive board and treasurer of Kidney Disease Improving Global Outcomes, better known as KDIGO. Up until summer 2011, he was chairman of the European Renal Best Practice, and up until autumn 2014, he chaired the Renal Disaster Relief Task Force of the International Society of Nephrology and participated in several international relief operations. Ray was founding president of the Belgian Society of Nephrology, is past president of the European Society of Artificial Organs, and past president of the ERA, the European Renal Association. He is now retired Professor Emeritus at Ghent University, and also past president of the European Kidney Health Alliance and of the European Chronic Disease Alliance. So, Ray, it's my absolute pleasure to hand over to you.
Okay, thank you very much. I'm put on my slide. Is this okay for you?
That looks great. It's not in presenting.
And now I go full screen.
Perfect. There we go.
Okay, and you can see sometimes it stops at the first slide. That's my second slide. That's okay.
The EKHA overview, 49 members.
Yeah.
Yep.
Okay. Then I start over here. Thank you very much for the very kind introduction. And this is a bit of an exotic topic, perhaps, in a green nephrologist webinar, because it's more about advocacy for kidney care. And the basis of all this is the work that have been done over the past 10 to 12 years, and actually still am doing for the European Kidney Health Alliance, which is a Brussels-based NGO that defends the case of the kidney patients and also of the nephrological community at the level of the European Union, and from there top to bottom also at the national level. The current presidents are Drs. Valérie Luyckx from Zurich and Michel Jadoul from Brussels in Belgium. For the time being, and just briefly mentioning that we are now representing 49 organizations that we have been growing progressively over the last 10 to 12 years, and that we really have become a go-to society or alliance if it is about kidney diseases. This is the summary of my talk. I will very briefly talk about the European Green Deal, give also a brief introduction to the EU policy structure, and then go to the bulk of this presentation, show you some of our advocacy tools and also some of the environment advocacy teams that we are focusing on, which of course is bidirectional, the environment on the kidney and the kidney on the environment. And this slide is summarizing what the Green Deal is about. It has been started in the previous EU legislation, that's in 2020, and is running through the current legislation up till 27. And the aim is to get the EU climate neutral by 2050. But we must also say that with the new legislation, they have been somewhat mitigating the way of progression, which is partly due to the fact that national governments and industries had a problem with the speed of progression, but also because the European Parliament has made a swing from the centrum left to the centrum right. And some of the topics that are in the box in the middle are really especially interesting for nephrology. It's about clean energy, sustainable industry, eliminating pollution, and sustainable mobility. Now, the basic structure of the European Union is triangular. We have the European Commission. They are the executive body. That means that they are doing things. It's like a government of a certain country. And they are controlled, on the one hand, by the Council of the European Union, that is the Council of the government leaders of the 27 member states, but you must know that there are also parallel councils for any of the subspecialties. So in what we are discussing here, that means that there is a Council on Health and there is also a Council on Environment. And on the other side, we have the European Parliament, and those are the only ones in this triangular structure that have been directly elected. Of course, the government leaders or the participants in the governments of the 27 states have also been elected, but that was on the national level. Those of the parliament have been elected on the European level. And in general, the Council of the European Union is most conservative, more conservative than the Commission. And that's understandable because the national governments want to keep their power and they sit on their money. And on the other hand, the Parliament is more progressive than the European Commission. So it's important to us to talk to all these levels. This is the current Commission. There are 27 commissioners. The president, as you all know, probably is Mrs. Ursula von der Leyen, who by coincidence is a medical doctor and who is German. And you can easily figure out that for 27 commissioners and 27 members, that means that each commissioner has been appointed by his national government. There is one per government, and they are running several different departments. For instance, there is a Directorate General on Health that is called, due to the old times, still in the French name, DG Santé. So the current legislation is running from 24 to 29. The presidency of the Council of the European Union is something specific because there is a rotational presidency, and that goes to one of the member states in an alternating system, which means that the system starts all over every 13.5 years. Before, when Britain was there, that was 14 years. And this is important because the presidency is defining the agenda of the European Commission and of all the discussions and debates. And then there is the European Parliament. We have 8 and as you can see, the ones in regression on top are the left-wing parties. The European Popular Party, which is central, had an increase in their seats, but the really great growth was for the right, the conservatives and reformists, and the extreme right, who call themselves now Patriots for Europe. It is important that this parliament has also a large number of hard-working committees on subtopics. And the committees that are of interest for us is the ENVI committee, which is on environment and food safety. Before, they also had health, but that has changed at the beginning of last year, because since then we have a separate committee also on health, which is called the Sant committee. Here is a summary of several of the tools that we are using. I'm not going to discuss this slide. It's just an overview slide. I made a selection of what we do in the following part of this presentation. The first thing we do is try each time to talk to the presidencies of the EU Council. Those that are marked in light blue are all countries with whom we collaborated. So the large majority of presidencies we have collaborated with, and particularly on kidney transplantation, that was done with Croatia, Portugal, then later on Spain, and also recently with Hungary, and I will come back to the latter at further down in this talk. But there were also many other topics like patient access or also more global themes. We also try to talk to the Commission. As I already said, for health, it is called DG Santé. In February 2021, on the left side, you have a snapshot of a conversation that we had directly with the commissioner at that time, the Cypriot Stella Kyriakides, together with 2 people with kidney diseases. That was in full COVID period. That's why it was done online. It is a bit more difficult to talk to the current commissioner, who is a Hungarian, Oliver Varhelyi, but we have good contacts with his cabinet because some members of this cabinet were also people with whom we collaborated on transplantation. And then we have the members of the European Parliament. They are very influential in the whole system, and they are the ones that are supporting us and defending all our main topics. We have only 9 parliamentarians, but they are very heavily devoted because they all are either health professionals or they have been Minister of Health, or like in the upper left angle, the current chair, Hilde Voutmans, she has had a family member with chronic kidney disease. And the one in the box is Ms. Romana Jerkovic, who was a biomedical researcher in Croatia, or still is a biomedical researcher in Croatia. And she is important because she is the first rapporteur to the European Commission on the European cardio-vascular health plan. And also about that, I will further have a discussion and details. We are organizing every year an European Kidney Forum in the European Parliament, where we bring together about 60 to 100 stakeholders, which are not only physicians, but all kinds of people, patients, nurses, health professionals of other specialties, health economists, pharmacists, insurers, administrators, regulators. And this is very important because this gives a very lively discussion that inspires us for further actions. It's always very interesting to be there because you have also an inside look at the European Parliament. For instance, Mark Harbour, who is one of the in the audience, has been there. So if you have the opportunity to join us, be welcome. And in this cyclus of fora, we had in June 2022 and also in June 2023 a forum that was related to green topics. In 24, because of the European elections, we had no forum, and last year's forum in 25 was on screening and on prevention of chronic kidney disease, which, as you understand, and also we'll see later on, also has a strong relationship with green nephrology. The current of the forum for this year will take place only in October or November of this year. We are publishing on topics that are of interest for us. I think we have now about 50 publications that all have some importance and are related mostly to socio-medical topics. And amongst these are 3 papers on green nephrology, 1 paper which made the basis of our actions that we after that have been doing on the Green Deal, and green nephrology that we published in NDT in 22. But there's also a recent one on a website calculator from the German Society of Nephrology for calculating the greenhouse gas emission of dialysis units. That's the paper by Beige and co-workers, which is on the right upper angle. And then below left, we have a kind of summary of the kidney forum that we had in 2023 that we published in Journal of Nephrology. And we are also publishing things not in official journals, but white papers, letters to the European Commission, or other documents that you can find on our website together with our publications. And below you see our Kidney Manifesto, which is a kind of roadmap of all the things that we want to accomplish during the current legislation, the mandate from 2024 to 2029. We are also active with World Kidney Day. Our most successful action, obviously, was the action in 2023, which was an awareness raising campaign with Tina Turner, where she came out into the open to declare that she lost her kidneys because she did not properly manage her hypertension. And that was something that was very well attended also at the other side of the Atlantic Ocean and had lots of comments. Unfortunately, Ms. Turner died a few months after this declaration. And we were also actively involved. We are actively involved in all World Kidney Days, but we were quite actively involved in the one of this year, where the topic was kidney health for all, caring for people, protecting the planet. Actually, the whole title and the whole discussion around this topic are most of or all the topics that have been discussed and focused upon by the European Kidney Health Alliance over the last 10 to 12 years. And specifically for this World Kidney Day, we were honored and happy that we could participate into the Kidney International editorial that is discussing the content of the title, and which is in fact a plea for sustainable kidney care in future. And we also had a webinar on the topic in the month of March, where we discussed the relationship between climate and kidneys. We're also involved in research projects, although we are not doing research. For that, we are too much understaffed, but we are doing endorsement and dissemination. One of the projects where we are involved in is Kidney Care, which most of you, I suppose, are knowing. It's an EU project looking for greener ways to promote a more sustainable model of kidney care. And on the other hand, I'm also involved in the Green K, which also is probably known to a large number of you, which is an initiative that is under the umbrella of the International Society of Nephrology and has been founded by a group of concerned nephrologists, amongst which Mark Harbour, who is in the audience, to obtain a greener concept of kidney care. And then perhaps the most important thing, which are the topics that we are discussing. Well, as I said already, this is bidirectional, and amongst others, it's about discussing the impact of the environment on kidney health, but always taking at the back of our mind that, of course, we cannot ask for a better impact of the environment on kidney health if we do not ask also at the other side of the coin a better kidney care that takes care of the environment. And in the role of the environment on kidney health, we are aware of the fact that the kidneys actually have a central position, which is known to very few people. If you look outside of the nephrology world, because of course they are the regulators of body volume, so they are extremely susceptible to heat. And on the other hand, they are also strong detoxifying organs, so any toxin they're in contact with is also damaging the kidneys because they all go through there, and pollution by definition is also very heavily affecting the kidneys. And on the other hand, extreme humidity and so on is also not good for the kidneys. There are a number of diseases that are flourishing, like malaria and so on, in flooded areas. And on the other hand, floodings, as we have observed very strongly during Hurricane Katrina, can also jeopardize dialysis treatment. Taking at the back of our mind also that people who are less educated have less advantageous working conditions, or are living in less advantaged areas are at higher risk. So people living where there is no greenery, no climatization, who have to do outdoor work and have no or not enough access to fluids are extremely vulnerable to the impact of the environment on kidney health. And then the largest part and last part of this presentation, the impact of kidney health and of kidney care on the environment. And one central point before we start to go into the details is that the awareness of the general population about kidney health and disease is dismal. And of course, policymakers are part of the general population. So awareness creation is really a core business for our advocacy activities of European Kidney Health Alliance. And that means also that you have to explain what it is about over and over again, and in most simple terms, preferably. And of course, I do not have to explain to you what is wrong with kidney care, and particularly with dialysis, and more for hemo than for peritoneal dialysis. It's consuming a lot of energy. In other words, producing a lot of greenhouse gas emission. It's producing a lot of waste, and it's consuming a lot of water. So nothing of that is good. And therefore, our idea is, and just simply also to explain that in all this discussion with policymakers, it's easier to go for the low-hanging fruit than for the more difficult ones. So the simple things like prevention work better in a certain sense than dialysis, because for dialysis you also have to explain the whole background. We are discussing everything, but prevention is an easier one than dialysis is. And of course, in prevention, first of all, I have to say that the best way to avoid a negative impact, whatever it is, of a certain treatment method, is to make that this treatment does not occur. And the first point is lifestyle. This is not an area for nephrologists. It's an area for politicians and for general practitioners. So here, I think our task is more educational than anything else, but also your task is educational, and you also have to bring everybody, every people or every person who is involved in kidney care or who is a patient has to bring this message, I think, to their surroundings or higher up on policy level. And not forget, in the right lower angle, that part of this primary prevention is also optimal treatment of hypertension and regulation of glycemia in diabetes, which is still suboptimal all over Europe, unfortunately. And of course, not forget that this lifestyle measures also have a positive impact on the environment. More greenery, no red meat, less greenhouse gas emission by cattle, less plastic for packed food, and also more exercise, so less greenhouse gas emission. But now, we live through a very fortunate area of nephrology, which I have been waiting on for about 50 or 45 years. So I have waited a long time to see now, when I'm out of practice, that finally we can do something more to refrain the progression of kidney disease. On the left side, I give you one example, is SGLT2 inhibition, but of course there is much more than that around for the time being. Not enough, but still we are in a better position than, let's say, 10 years ago. One of the concerns is, of course, that drug production by itself also is a greenhouse gas emitter, and that has been elegantly studied by Talbot et al. On the right side, where you can see in the pink bar the greenhouse gas emission of the production of an SGLT2 inhibitor. So obviously there is greenhouse gas emission, but it's largely compensated on the right side by the green bars with a lower quantity of hospitalizations and also a lower quantity of maintenance dialysis sessions. But no prevention without adequate screening. So one of our other battle horses is to have a better and systematic screening of chronic kidney disease, and in fact of all diseases in the cardio-renal metabolic axis by EGFR, but which is a relatively late marker, but particularly by albuminuria as an earlier marker, which has elegantly explained to you a few months ago, I think, by Alberto Ortiz. And in the blue box, you can see data from a Dutch screening study by the group from Gansevoort for about 5,000 people, wherein 150 albuminuria was found, and this gave a new diagnosis. So diagnosis of unknown disease for 50 diabetes and pre-diabetes, 44 hypertension, 27 CKD, and 93 dyslipidemia. Of course, that means that several of these conditions came together in a number of patients. But if you should see these data, our conviction is that this screening should not be done not only in the risk group, but also in the general population. And something that we are fighting for heavily is that albuminuria testing would be reimbursed all over Europe, not only for diabetes, but for the general population, and, for instance, be coupled to colon cancer screening. In this context, we have been also part since many years, since the very beginning in the European Alliance for Cardiovascular Health, abbreviated EACH, where we had to fight quite a lot to convince this group that chronic kidney disease also was a major cardiovascular risk factor, and vice versa, that cardiovascular disease is a major kidney risk factor, and that if they wanted a good prevention of cardiovascular disease, chronic kidney disease should be included into the picture, because otherwise their efforts would be partly futile. And this worked quite well after some time. The infographic, which you see on the left side, is a result of this activity. And with the EACH group, we were able and happy that the European Commission, after its 30 years of focus on cancer, now also saw that there were more chronic diseases than that, and they decided to develop an EU cardiovascular health plan that they called the Safe Hearts Plan. Of course, we would be more happy if there would be a kidney disease plan. But for the time being, I think that it was good to have this Safe Hearts Plan, and we jumped on the bandwagon, and were also very active to be involved in a group that offered advice to the European Commission on what they would have to write in their plan on cardiovascular screening. And that was developed by a group of collaborating specialties, so the cardiologists, but also nephrologists, diabetologists, and obesity specialists. And we wanted to convince the European Commission, we will see what they're doing with it, to have systematic health checks at least every 5 years for those older than 35 in the general population, and every 2 years for those above 65, and opportunistic health checks, and health checks for people at risk below the age of 35. And then we tried to suggest a number of minimum tests. There were, of course, a number of cardiologic tests included, hypertension also. But we were very happy that in the text there was also repeatedly mention of albuminuria and of EGFR, and also that the usual term of cardiovascular or cardiometabolic was replaced by cardio-renal metabolic. And now we hope that the European Commission will develop this further. I must also say that we also have seen already a first outline of the plan that contained only 3 mentions, I think, of kidney disease, that we managed to increase that number of mentions of kidney disease. But of course, we would like to have more and weigh more on the Commission to include the kidney aspect in their text, and therefore our very good relationship with Ms. Jerkovic, which I mentioned before, the parliamentarian who is the first rapporteur to the Commission on their cardiac health plan, is very useful. But it's not only prevention, it's also transplantation. I will not go very much into detail, but as you can deduce of the bars, the height is indicating the frequency of transplantation per country. This is extremely different among European countries. Then the colors, the light blue is living donation, the dark blue is deceased donation, and the orange or pink is after cardiac death. And here also it's clear that there are huge differences among European countries, and that a lot of countries are not exerting or virtually not exerting transplantation after cardiovascular death. So in the area of transplantation, a lot of progress still has to be made as well. But of course, the new question is, and what about dialysis? Because that's the real culprit. If our main topics are awareness, detection and treatment, and high quality care where transplantation is part of, then in the box you see that also innovative dialysis solutions are there. And here our focus is essentially on home dialysis. I forgot in the slide to mention peritoneal dialysis, but of course that's also one of the topics that we are working very strongly upon. And here there are now enough data from Australia that PD, obviously, although it has a carbon footprint, at least the carbon footprint is lower than for hemodialysis. But we're also struggling very hard for more attention for home hemodialysis, which is, of course, not only a policy question, but in part also a policy question. On the other hand, also a question to convince the nephrological community. And one of the reasons why we are doing is illustrated on the left side. It's the shortage of personnel, of healthcare personnel, and therefore also we're working for a more compact dialysis system, a recycling dialysate system, that this would be introduced, because that would give cheaper and more ecologic dialysis. In conclusion, what to take into account when advocating? Well, everybody should be an advocate. And this is not only EU, but it is also national and regional and local and in your own surroundings. And that the awareness about kidney disease is low, so we have all an educational task. Never be frustrated, because we have to continue to hammer on the same nails all of the time. And the message should rather be sustainability than environment, because there are also other aspects: the cost, the quality of life, morbidity and mortality, and of course, environment. And finally, most policymakers are eager to learn, but they must be informed. You have to bring simple messages, preferably only 3 main points, maximum 5, and give them clear to-dos, because they are doers. They want to do something. And that brings me to the end of this presentation. I hope I was not too long, and I thank you for your attention.
That was wonderful, Ray. Thank you so, so much. And not too long at all. It was the perfect length. It was a fantastic lay of the land in terms of everything from the European level, and finally what we can do at a national and a local level. There are so many bits that I want to touch on, but I think I'll open it to the floor first for questions. If people are comfortable to turn their cameras back on, please do so to facilitate the discussion. Mark.
Thank you, Ray. Super talk. It always amazes me how much this group has done. I think you and I have touched on this before, but just going back to the transplantation bit, the the carbon footprint of transplantation is probably about 5% of that of dialysis. As you know, it's much cheaper, but basically it's just better treatment. And I'm just putting, and again, I know there's data, but for everyone else, the divide is even worse if you look at the dialysis transplant ratio in European countries such as Germany and what have you. And I guess I'm trying to say is how does one influence the European Commission to say those patients in Germany and elsewhere that have this poor ratio are likely to do a lot better, plus it will be cheaper and so on. It seems astonishing that there's such a variation.
Yeah, I did not go much into detail, but we have been working very heavily on transplantation, and we have written a joint statement that's something that's commissioned by the European Union themselves, kind of advice guidelines on how to promote transplantation. And then later on with the Hungarians, we have had actually a very strong focus on transplantation during their health initiatives. That was in the second semester of 25. That emanated in another council declaration. So there was not only the council declaration on cardiovascular, but also on transplantation. But unfortunately now the European Union is not following up as strongly as for cardiovascular. Usually they take only one of the topics. So we actually have to and are busy in pointing them out that they also should do something on transplantation. But again, it's not only a question of the European Commission, it's also a question of the national governments. So everybody, also in Britain, but that's your own local question, but every EU country must be also influenced and politically influenced. And I think therefore, it's really needed to collaborate with the patients also, because they have a stronger voice than nephrologists. Politicians probably correctly don't trust doctors, and also there are more patients who vote for them and their family members than there are doctors. So the patients really play a central role. So also in everything that we are doing, we are involving patients, because I think without them, this European Kidney Health Alliance would be much less strong.
I see there's a couple of questions in chat. Matt put a question in about number needed to treat and needed to harm. Matt, do you want to come off mute? And
yeah, it's just on the cardiovascular health checks that there are in the news today in the UK was mention, or this lunchtime was about prostate screening, for example, and how there is more harm being done for a national screening programme than benefits. And so for the cardiovascular checks, what would be the numbers needed to treat for an opportunistic or a systematic health check at under 35 or over 35, knowing that there are harms from a screening programme as well?
Yes, yeah, that's obviously there are always, I think in this whole discussion, there are a number of extremes, and I can believe there are some harms, but the focus for us is that economically, for the time being, what we are doing, it's not feasible. Dialysis, as we are doing it right now, and the way we are treating kidney disease with our focus on the end of the spectrum, which is very important, but it is not the only thing that makes that it is extremely expensive for societies, and that it is also extremely burdening for the environment, not to take away everything that it's doing to patients and to their families. So I think the harm done by the disease in its course, which is not only by dialysis, but also everything that happens from the moment that uremic toxicity develops, because I have all my life also been working on the cardiovascular impact of uremic toxicity, and that's not happening when people are on dialysis, but that's happening 20 years before. So I'm very strongly convinced that screening and prevention is better than doing nothing. And it's better for people. People will be more happy and their life will be better. But the sustainability is the big topic. And then you have to imagine we are relatively well off because our countries are still rich. But what is happening in Africa for the time being, and where screening programs would be much more useful, be it only for hypertension, for instance, than what they are doing now, which is dialyzing people, making a kind of selection based on mostly social standards, dialyzing a few people and then making these people that poor that at the end of the day they can't pay anymore and then they die anyway. Then I think there are more logical ways to do than what we are doing right now.
There's a question from Eleanor Murray in chat. I'm not sure if she's able to come off of mute or not, so I'll read out. I had not realized Netherlands' living donor rate was so high. It looked like 42 persons per million, far higher than what we were even ambitiously aiming for. I'd like to know what their approach is.
Well, their approach is that they're very bad in deceased donation. That's actually the answer. We're bad because the law in the Netherlands have been changed. These are data, I think, from 23 or 22, which I showed in the slide. And just before COVID, they passed a law where they changed from opting opting out from opting in to opting out. So that means that now Dutch people who are potential candidates for transplantation can be transplanted without previous consent. And the Dutch people I know say that their deceased donation rate has gone up. I did not see yet the data. But of course, the data are skewed because all this happened just before COVID. And with COVID, also the whole transplantation program was scrambled up. So I think we need some more time to see what happened. But I'm convinced that their deceased donation program will increase over time. And they are very good in cardiovascular death donors. But that's only one center, or mostly one center in Maastricht, which is doing this.
I see no hands up, which means I get to ask my question, which is fantastic. I really appreciated the schematic of how the European Commission sits with the Council, with Parliament, how those tie in together. I just wondered, with the context of, say, policy papers, do they therefore have to be aimed at, say, the Commission because it's them who will propose legislation, or does it get, I guess I'm wondering, policy papers, who are they written for, at what level, and how does that sort of translate into legislation?
But do you mean peer-reviewed papers in journals, or do you mean the rest, the white, the letters, like etc.?
Sorry, yeah, policy briefs.
The letters. Yeah, I think that we are aiming in many different directions, but our relationship with parliamentarians is totally different from our relationship with the Commission or with the Council, and the Council is also something different. So if we're writing letters, it's mostly directed at the Commission. But what we also want, and what we now are doing, is to distribute those letters, and all of our material is distributed among our members, but we ask explicitly our members to work also on the national governments, so that our letters are also reaching the national governments, so that bottom up approach, the Commission is convinced the other way around. For the parliamentarians, it's really direct contact. And so we have the 9 parliamentarians, but we also have contacts with non-members, with many members of the Sant Committee. So that's something that's more like a more or less friendship relationship, even, where we are very direct, and that's very, very useful. And then the council is still something different, because of course there you have to prepare your thing. So you see it coming, you start trying to contact the national government via the national societies or whatsoever, when they 1 year before or even earlier, try to find something in what they are interested in to hook your wagon on. And if it's not possible, then you try to organize something together with them on whatever topic that is of interest. So it's a bit more flexible. But the best thing is, of course, that you have a very close relationship, like we had for Croatia, and with Hungary on transplantation, was also very good with Belgium, but that was more on accessibility for patients. With France was very good, because that was through them, and that's only in 2022, for the first time, kidney disease was mentioned in an official document of the European Commission. And with Cyprus, it's also working pretty well. So it's a bit depending. With Germany, it did not work at all. With Sweden also. So it's you have to see whether the mayonnaise takes or doesn't take.
Superb metaphor. I love that. And I think that's probably the perfect note for us to bring this webinar to a close. Ray, thank you so much for your time, for presenting, for outlining so many different aspects. It's really, really appreciated. A couple of things that came up that are relevant, just to remind people. The paper by Joachim Beige on the website Calculator benchmarking carbon footprint of hemodialysis will be presented in July's edition of this webinar series, so be sure to join for that. And next month we have, just check the schedule, Dr. Ayushi Gupta, who is a renal registrar at Hammersmith, who will be speaking through some renal quality improvement projects that they have done. So on the ground changes that they've made, impacts that, that they've managed to achieve. So definitely join us for that one, which is the 25th of June, 2 to 2:50, with a couple of minutes overrunning potentially. Thank you everybody for joining. Thank you especially Ray for presenting, and have a brilliant rest of your days.
Okay, thank you.